go on now to thinking about how health gets to be the business of politics and economics at all. Okay? There are lots of things about our lives that don't get so highly elaborated as this. But as the basis for understanding healthcare systems, what they're trying to do, when they came into existence, and what's driving them, it's good to go back to the United Nations Declaration of Human Rights and the inclusion of health as a human right at that time, post-World War II, and its connection at that time and since with other human rights like food, housing, work, education, information, and social participation. So the World Health Organization was established to prosecute this human right, that is, to advance it around the world in all of the countries that wanted to sign up, with an agenda to increase freedoms, such as the freedom to control your own reproductive health and the freedom from being forced to participate in medical experiments without giving consent, and the entitlement to some level of health protection that is equitable and reasonable. So the World Health Organization itself, in its planned goals for the period 2019 to 2023, had these triple billion goals. 1 billion more people than in 2019 having universal health coverage. 1 billion more people with better protection from health emergencies, and 1 billion more people around the world enjoying better health and well-being. And of course, it's important to remind ourselves that not all people are treated equally in all healthcare systems, and there are particular groups who have been noted as being at higher risk of not being able to access health as a human right, such as Indigenous peoples, people with mental illness, sex workers, drug users, and transgender and intersex people. So health is a human right. How does that get us to political economic systems? The international treaties listed on this slide, the International Covenant on Economic, Social, and Cultural Rights, and those other treaties there, the Convention on Racial Discrimination, Discrimination Against Women, Rights of the Child, and Rights of Persons with Disabilities, all say something about health as a human right. So if you're a country that has signed on, is a signatory to these treaties, then you're making a commitment to ensure health care access for the people in your country and to provide also for those underlying factors that determine health, determinants of health, like food and water, sanitation, housing, education of women, immunization of children, etc. Some countries do this in a particular way with government-funded approach, and some countries take a free market approach to this. Regardless of which model a country takes, there is also a less formal healthcare system which really often doesn't take account very well of the amount of unpaid health work that's done by families, volunteers, community, active people. Also, it doesn't take account of alternative and complementary therapies that are off the radar of government funding and government regulation. And it may not take account of health activist groups or philanthropic and charitable organizations that have a health mission. So there's some level of formality and some level of informality in a healthcare system overall, in its political economic activity. Universal health care, which is the top model, where your government says, yep, at some level, we're going to look after everybody here with taxpayers' money. Has pros and it has cons. Okay, they're set out on this slide. There is no, again, this is a complex system. There is no clear winner here. There's nothing that works perfectly. This is another slide talking about universal health care, much more detail than we need to focus on tonight, but comparing the single-payer model where the government provides free health care, all paid for from taxes, and the government pays health care providers to provide that service to citizens. Then there's another model of mandatory insurance where everybody has to buy insurance, sometimes through their employers, and there's private provision of the services that's funded through this compulsory insurance. Then there's a national health insurance model, different approach to insurance and which way the money flows and how providers get paid. And then there is a model which is more privatized, where you may be expected to pay entirely out of pocket for what health care you seek. And your choice of insurance is optional if you can afford it. The United States is often singled out as one of the, is the only one of the developed countries in the world that does not have universal health care, but it does for specific parts of its population, for example, veterans and people on certain kinds of income levels. So there are lots of comparison tables when you look at healthcare systems, when you study healthcare, looking at the pros and cons of different models of running a healthcare system politically and economically to try and get the best value for the most people in the most sustainable and efficient way. There's a lot in health economics about that. The takeaway message from this slide, another comparative slide about how health spending is allocated by governments, by compulsory health insurance, by voluntary health insurance, by out-of-pocket, and by other sources across countries from Norway through to India. The takeaway message on this slide is that the health systems that we have today are overburdened. Mostly the costs are not sustainable in the long term. And if we expect the level of health care that we receive today to stay as good or to get better, to take on board new medical advances, new breakthroughs in research, it's going to be difficult to fund this from public resources using the healthcare system models that we have today. So often this is where information and communication technology vendors and big consulting companies that work with them will come in and say, we can fix that with technology. That's for you to decide as you go through your studies, whether you think that's working or not. So I want to talk now, moving from political economic systems to social and technical systems. And the technical here is in the sense of techniques and technicalities. We're not specifically talking about information and communication technology here, but we're talking about an aspect of human existence where we have social structures, where we set up special groups, and it's not an even experience for everyone in this life to do the work and to experience the services. You need to have special skills. You need to be specially certified in some way. So if I decide I'm going to set up a nursing school tomorrow in my house and train nurses. Can I do that? Yeah. No, not really. I mean, nobody's going to stop me, but nobody's going to hire anybody that I train because I'm operating outside of a regulatory system. We regulate the way our health professionals are educated and how they are certified to practice, what they are and aren't allowed to do in their scopes of practice, how much professional development they need to have, what codes of conduct they need to follow, etc., etc. So it's a field full of technicalities, the healthcare system, around who can do what. There are also chronically shortages of people who have the skills in particular areas, in particular regions of countries and of the globe. There are lots of ways of categorizing the kind of work that's done, and the nature of the professions is quite well defined, but this excerpt from Wikipedia shows in 11 dot points the different flavors of health worker that you might have, for example, in gerontology, or in oral care, or in public health. Lots of different kinds of health professionals might work in a particular domain of health and do particular kinds of work. So also, in this social technical system, there are other workers in the workforce who are not entirely as strongly regulated, mostly at one remove from patient care. But in the study that you're going to be doing after today's lecture, in the ways that you're going to be thinking about how we apply information and communication technology in health, you have to keep this workforce in mind as well. So people who manage health services and administer them, people who are specialized workers with health data and health information, economists, educators, supply chain managers, and so on. I'm going to skip to the next slide and just say, and let's not forget people who are doing research and development, sometimes in the public sector, sometimes in the private sector. People who do biosurveillance, brain research, clinical trials, who work with consumer behavior and marketing, drug development, genomic research, medical technology, public safety. So in the whole socio-technical system of healthcare, there are lots and lots of areas of work. So it's not just about doctors and nurses, okay, and allied health professionals, and maybe public health officers. It's about a whole lot of other people, all organized into particular social structures and social groups, working together to some degree or other in some settings. And I included this Global Biodefense magazine cover from February, simply because in the featured articles it illustrated around the topic of the coronavirus many of these different aspects of R&D in healthcare. So this talks about clinical trials and public safety and consumer behavior and all the rest of it. It also is a great illustration of the commercial interest around the world in biosurveillance itself, that this magazine exists.